that we should kindly put our phones either in silence or vibration, or put it off totally. Thank you.
Thank you very much. Please kindly be seated. I'd like to welcome everyone to the 400th of our inaugural lecture series in Haematology University. The lecture is to be delivered by Professor Salawu Lateef, a professor of Hematology and Immunology. And the title of the lecture reads, Blood is Health. Our blood mirrors our being. Professor Lateef Salawu graduated from the University of Ife, now OAU, Ile-Ife, in 1987 with a BSc and an MB-CHB in medicine and surgery. He went through the residency training in hematology at the Haematology University Teaching Hospitals Complex from 1992 to 1998. He received fellowships from the West African College of Physicians and the National Postgraduate Medical College of Nigeria. In 2003, he earned an MSc in chemical pathology from the University of Ibadan and a Doctor of Medicine degree from the National Postgraduate Medical College of Nigeria in 2020. Professor Salawu joined the services of OAU in 1999 and rose through the ranks to become a professor in October 2011. He served as the acting head of the Department of Hematology and Immunology from February 2007 to July 2011, and he became the substantive head on 1st August 2020, continuing until 31st of July 2021. Moreover, he held the position of Dean of the Faculty of Basic Medical Sciences from the 1st of August 2021 to 31st July 2023. Additionally, he served the university as a Senate representative to the University Development Committee and the Finance Subcommittee. Professor Salawu is a consultant hematologist to the Haematology University Teaching Hospital Complex and the head of the Department of Hematology and Blood Transfusion between February 2007 and July 2011, and also from 1st August 2020 to 31st July 2021. He's a fellow of the International Chronic Myeloid Leukemia Foundation and received a grant of $10,000 in July 2011 for the diagnostic testing, treatment, and monitoring of CML patients in emerging regions. Professor Salawu was the acting chief medical director of OATHC in Ile-Ife from the 5th of July to the 20th of September 2023. He serves as an examiner for the West African College of Physicians, the National Postgraduate Medical College of Nigeria, and several medical schools across Nigeria. He has authored over 80 publications in both Nigerian and international journals. He has supervised more than 30 candidates, professional and academic theses, including 4 MSc and 2 PhD candidates. Professor Salawu is married and blessed with children. I have the single honor to present to you Professor Salawu, who is to deliver today's inaugural lecture. You're welcome.
The Vice Chancellor, sir, the Registrar, esteemed ladies and gentlemen, I express gratitude to the Almighty God for allowing me to stand before you all today to deliver this 400th inaugural lecture. After my secondary modern school education in 1973, I never expected to have a university education. Intended to learn a craft at the trade center, though I obtained the admission form, as fate will have it. My name was missing from the list of those to take the aptitude test for selection. But here I am today, not only having had a university education, but with additional favor from the Almighty God to deliver this inaugural lecture, the fourth since the inception of the Department of Hematology and Immunology. The blood, the symbol of life and vitality. Blood symbolizes life and vitality. Biologically, it represents continuity as it carries genetic information across generations. Culturally, blood often symbolizes sacrifice, kingship, interconnectedness of life, and identity. Physiologically, blood is the vital fluid that serves essential functions in the human body. Blood signifies life and death simultaneously. Life through its circulation and nourishment of the body, and death through its loss and spill. It comprises the cellular elements and the plasma. The cellular elements, the red blood cells. The red blood cell transports oxygen from the lungs to all the body cells for essential metabolic processes and remove carbon dioxide, a byproduct of metabolism, from the cells back to the lung. In addition to all these physiologic functions, the red blood cells also carry antigenic molecules on their surfaces that can be used to identify our type of blood, which is also used for incompatibility testing before blood is transfused. The red blood cell antigen are also useful in forensic investigations and genetic studies, including paternity testing and the investigation of human ancestry and migration patterns. White blood cells. The white blood cell protects the body from pathogenic organisms and other foreign substances by directly destroying these substances and also producing antibodies and cytokines that can eliminate them. The leukocytes also carry genetic information in their nucleus, which contains the instructions necessary for all cellular processes and functions of the body. The genetic information in the nucleus can also be analyzed for medical and legal purposes, particularly for identity verification and established biological relationships. The human leukocyte antigen, HLA, on the surface of white blood cells are vital for matching donors and recipients in organ and tissue transplantation to minimize the risk of rejection. Identifying specific HLA types linked to disease can aid in early diagnosis, risk assessment, and effective treatment. The HLA is also instrumental in immune system regulation by differentiating between self and non-self, thus preventing autoimmune disease and enabling immune responses against infections. Furthermore, the antigens influence how individuals react to vaccines and medications, impacting both effectiveness and side effects. Platelets. The platelet, in conjunction with collagen protein in the blood, prevent blood loss from the intact blood vessels. And when there is an injury, by helping blood to form a clot and sealing any opening in severe blood vessels. In addition to this primary function of preventing blood loss, the antigens on their surfaces affect platelet transfusion, as mismatches can lead to immune reactions and destruction of platelets. These antigens also assist the immune system in distinguishing between self and non-self, thereby preventing unwanted immune responses. Furthermore, platelet antigen can influence the outcome of organ and tissue transplantation by affecting immune compatibility between donors and recipients. Plasma. The plasma contains coagulation protein, an antibody that protects the body against infections. It also transports nutrients and cells to generate and remove metabolic products for excretion. Plasma albumin helps maintain blood volume and osmotic pressure. The plasma also distributes hormones and enzymes that regulate metabolism, growth, and other body vital functions in the body. It regulates acid-base balance and carries essential electrolytes for nerve and muscle functions. The specialties of hematology and immunology. Hematology is the branch of medicine and biology concerned with studying blood and disease of blood and blood-forming organs. It is a unique specialty that combines laboratory and clinical aspects of medicine. Hematologists are therefore involved in the laboratory investigations and management of patients with hematological disorders. Immunology, on the other hand, is the study of the immune system, a complex network of cells, tissues, organs that defend the body against foreign invaders and disease. Historically, immunology has been an important branch of medical and biological sciences. It emerged from the observation that individuals who had recovered from certain infectious diseases were not reinfected by the same disease, indicating that they had developed immunity. However, the earliest written reference to immunity comes from Thucydides, an Athenian historian and military general in 430 BC, who wrote that only individuals who had recovered from disease would not be reinfected a second time and could nurse the patient. In his observation, the same man was never attacked twice, never at least fatally. He made this observation in his writing on the Peloponnesian War, during which the plague killed nearly a third of the Athenian population. This can be considered an astute observation, recognizing that after an individual is exposed to a pathogen, they may be protected from disease upon subsequent exposure without solving the effect of infection. The term immunity is derived from the Latin word immunitas, which refers to the exemption of a community or an individual from obligation to the Roman state or a local community. However, in medicine, immunity means protection from disease, specifically infectious disease. The study of immunity started with microbiologists who made several observations that linked immunity of host animal to the entry of foreign substances. My career development in hematology and immunology. Upon completing my specialist training in hematology at the Obafemi University Teaching Hospitals Complex, I was appointed lecturer 1 in the Department of Hematology and Immunology in 1999. At the time of my appointment to the department, there were 3 academic staff teaching hematology, but only 1 for immunology. Consequently, I was encouraged to consider including immunology alongside my primary training in hematology. The need became even more compelling as the department was unable to find a replacement for the retired clinical immunologist at that time. Through self-efforts, including attending the update courses on the molecular and cellular basis of normal immune response given by Professor C.P. Miller from Luxembourg at University College Hospital, Ibadan, a master's degree in chemical pathology from the University of Ibadan, with my thesis written on immunology aspect. Short courses in immunology organized at the Makerere Uganda Virus Research Institute in Uganda and the South African Immunology Society in South Africa. I acquired the necessary knowledge in basic and clinical immunology to teach immunology to students. With my background in both specialties of hematology and immunology, my teaching activities and research interests shifted from pure hematology to immunohematology. As I earlier alluded to, hematology is the subject of the study of the physiology and the study of blood constituent and blood-forming organs. Immunology, on the other hand, is the study of how the immune system works to defend the body from infectious disease and harmful substances. The tools in both fields are essentially the same, blood and cell structure. Therefore, both specialties of hematology and immunology are interwoven, and as such, the research activities that I'll be highlighting today will involve both. My contribution to knowledge. Blood is a unique connective tissue that links all organs, tissues, and cells within the body and facilitating their interaction. In addition to delivering oxygen and nutrients to the body cell and removing carbon dioxide, another byproduct of metabolism, it also serves as a medium for transmitting information between cells through chemical signals that govern all biological processes in the human body. Therefore, any changes in its composition will reflect alterations in the individual cell throughout the body. Thus, beyond its physiological functions, blood contains a wealth of information regarding an individual's health status, making it an invaluable resource for understanding the causes of disease, aiding in accurate diagnosis, guiding treatment decisions, and monitoring the effectiveness of treatment. For instance, detecting antibodies to HIV in the blood indicates the presence of HIV infection in that individual. Similarly, alterations in the cellular composition of blood may signify some pathological process in the body. For example, complete blood count result indicating that any of the cellular elements count outside the reference values or abnormal morphology in the cells may suggest infection, hematological disorder, or other forms of pathological processes in the body. Therefore, part of the laboratory physician's responsibilities is to analyze the blood and provide an interpretation to the ongoing pathological processes. Because of this, blood can be likened to a mirror that reflects both normal and abnormal processes ongoing in the human body, or a window through which we can view our health status. Understanding how blood reflects our health status can empower us to take proactive steps towards preventive care and early diagnosis, as it provides a dynamic snapshot of our physiological state. Hence, this inaugural lecture is titled, Blood is Said, Our Blood Mirrors Our Being. Mr. Vice Chancellor, sir, with your kind permission, I will highlight some of my contributions to knowledge in the specialties of hematology and immunology, including blood transfusion medicine, under the following 5 subheadings. 1, autoimmunity. 2, diagnostic immunology. 3, determinants of survival in hematologic malignancies. 4, immune suppressions and anti-cancer drugs. And lastly, modern innovations in blood transfusion safety in the last 2.5 decades. My contributions to immunology. Immunology plays an essential role in disease diagnosis through serological testing to detect and measure antibodies or antigen, identify and measure immune responses to antigen, detect specific immune markers in tissues and cells, determine immunity level post-vaccination, and identify autoantibody attacking the body cell. Because immunology enables an accurate and early detection of disease, I conducted some study on immune-mediated disorders. Autoimmunity, a paradox of self-identity and self-preservation. Under normal circumstances, an individual does not produce substances that can cause harm to their own body, but to foreign substances. This is because during the development and maturation of the cells of the immune system, the lymphocytes that will react against self-tissue are eliminated in the thymus for failing the thymic education. Hence, this provides an immune system that is tolerant to the host. This self-tolerance is maintained by a network of lymphocytes and their products. The causes of autoimmune disease are not fully known. However, a breakdown in the immune mechanism of self-tolerance, some hormonal and lifestyle factors, molecular mimicry, interaction between genetic factor and environmental toxin have all been suggested to be responsible in many cases. Immune system disorders are uncommon in the indigenous African population due to the high prevalence of infectious and parasitic disease that impairs the host T-cell immunity. Because of this observation, I conducted some study to ascertain the veracity of the assertion. 1. Immune thrombocytopenic purpura, ITP. ITP is a bleeding disorder resulting from the destruction of platelets by autoantibodies produced in the affected person. Individuals suffering from ITP usually present with hemorrhagic manifestations such as gum bleeding, epistaxis, mucocutaneous bleeding, gastrointestinal tract bleeding, and heavy menstrual bleeding in women, all as a result of severe platelet destruction by autoantibodies against the platelet antigen. Affected individuals may also bleed into the brain, and this may be fatal in some cases. I investigated the pattern of presentation and the effectiveness of treatment available to patients presenting with ITP. The diagnosis was based on mucocutaneous bleeding, thrombocytopenia, and examination of the bone marrow for quantitative and qualitative abnormalities of the megakaryocyte responsible for producing the platelet. Twice as many females as males were recorded. More than 8% of them presented with gum bleeding, while others presented with purpura, hematuria, epistaxis, hematemesis, and menorrhagia. 3 of the affected patients also had a positive family history of similar disorder. Moderate to severe anemia occurred in more than 90% of them. 80% of the affected patients presented with severe thrombocytopenia. More than 80% of them required blood transfusion in addition to steroid therapy, while one of them, in addition, required immunosuppressive therapy to be in remission. Over 11 years, only 11 cases were managed out of over 200,000 clients seen in our facility during the same period, resulting in a period prevalence of 0.005%. Autoimmune hemolytic anemia. Autoimmune hemolytic anemia is another disorder another autoimmune disorder in man, in which individuals produce antibody against their own red blood cell, with consequent destruction of these red cells in the reticuloendothelial system, particularly in the spleen or within the blood vessel, and may then be associated with passage of red-colored urine or hemoglobinuria. This causes a shortened survival of the red blood cell. I reviewed the record of patients managed for autoimmune hemolytic anemia over 10 years. The diagnosis was based on features of hemolytic anemia and a positive Coombs test after excluding other causes of hemolysis. There were more females than males with a median age of 42. 60% of cases were associated with secondary disorders such as hematological malignancies and collagen disease, while the rest were idiopathic type. Investigation led to the identification of autoantibody responsible for the disorder of red blood cells in approximately 77% of cases. All had moderate to severe anemia that required blood transfusion in addition to steroid therapy. The study also confirmed the rarity of immune-mediated disorder, as only 13 cases were managed over 10 years out of over 400,000 new clients seen within the same period in our facility, giving a period prevalence of 0.003%. Lupus anticoagulant. Lupus anticoagulants are acquired antibodies, first described in SLE, but have now been associated with other disorders. Interest in this group of antibodies resulted from the association of lupus antibody with venous and arterial thrombosis, autoimmune hemolysis, and thrombocytopenia. HIV infection is known to cause polyclonal activation of B lymphocytes. Some of the resulting antibodies may have lupus anticoagulant specificity and may be directed against self-antigen, which therefore explains some of the clinical and laboratory features of HIV/AIDS. We studied 104 consecutive heart-naive adult patients with HIV/AIDS in an attempt to determine the prevalence of lupus antibody and their significance. Of over 100 clients investigated, only 3 were positive for lupus antibody. A similar study was also conducted in the pediatric age group. 116 HIV-negative children and 61 healthy HIV-negative age and sex matched children were investigated for prevalence of lupus antibody and its clinical and laboratory impact. Of the 116 subjects, only 7 were positive for lupus antibodies. There was no significant effect on the patient's hematology level, leukocyte, or platelet count. There was also no correlation between the occurrence of lupus antibody and opportunity infection or thrombosis, similar to what was found in the adult study. These studies confirm the low prevalence of lupus antibody in our patients, but without thrombosis, opportunity infection, anemia, or thrombocytopenia. These studies support the observation that autoimmune disorders are not common in the indigenous African population, and that females are more affected. Although studies support the observation that autoimmune disorders are not common in the indigenous African population, including Nigeria, total prevention of immune-mediated disorders would be the ideal, because how can one explain a situation where the body's immune system mistakenly attack its own healthy cell, tissue, or organ, treating them as foreign invaders? Why there is no guaranteed way to prevent autoimmune disease? Preventive strategy to prevent autoimmune disease include maintaining a healthy gut by eating a balanced, high-fiber diet with lots of fruits and vegetables that will maintain a healthy gut microbiome, which is essential to immune function. Avoidance of ultra-processed foods that promote inflammation and disrupt the immune system. Smoking is a known factor for several autoimmune diseases and should be avoided. The use of personal protective equipment in people working with heavy metals and pesticides will limit their exposure to this environmental toxin. Good hygiene practices, vaccination, and early infection management will help prevent autoimmune disease, as some viruses and bacteria are linked to triggering autoimmunity. If there's a family history of autoimmune disorder, regular medical checkups and symptom monitoring are advisable for early intervention. Diagnostic immunology, the role of biomarkers in disease assessment. The assessment of serum immunoglobulins, antigens, cytokines, immunocytes, and other immunology biomarkers plays a critical role in disease diagnosis, as they serve as biomarkers of immune response to infection, autoimmune disease, allergies, and immunodeficiency disorder. For instance, CD4 positive T lymphocytes are essential for immune functions, and their decline in HIV is a key indicator of disease progression. Changes in CD38 and CD56 expression on immune cells can be prognostic indicator of ITP. CD19 and CD20 are markers of lymphoid malignancies. CD13, CD15, and others are markers of myeloid malignancies. CD3, CD4, CD8 are markers of T lymphocytes, while CD19 and CD20 are primary markers of B lymphocytes. High serum level of IgM indicates recent or acute infection. High IgG indicates past infection or that the individual has developed immunity. High IgA indicates mucosal infection. Low levels of the immunoglobulin, that is IgM, IgG, and IgA, suggest primary immunodeficiency disorder, while IgE levels are elevated in parasitic and allergic conditions. Monocular IgG or IgM suggests hematological malignancy such as myeloma or worrisome macroglobulinemia. The immunoglobulins are also helpful in monitoring disease progression and response to treatment. Because immunology-based diagnostic methods are precise, fast, and essential for early diagnosis and management of disease, I conducted studies to assess the role of some immunologic biomarkers in some disease conditions. 1. Schistosomiasis. Schistosoma hematobium is a blood fluke that infects the urinary tract and is prevalent in Africa and the Middle East. It is the primary agent of schistosomiasis and one of the most widespread parasitic infections in developing countries, especially in rural communities, where drinking water is contaminated by fecal matter and urine that harbors the parasite. The presence of its eggs or worm in the female genital tract is common and has been linked to infertility, ectopic pregnancy, and low birth weight. Most reproduction-related effects of female genital schistosomiasis have been largely attributed to the mechanical impact of the gloma formed by the schistosome egg with limited immunological evidence. In my MSc research, I investigated several aspects of the immune response to schistosomiasis by studying 408 pregnant women and measuring serum level of some immunologic biomarkers. Significantly elevated serum IgG was observed in pregnant women with urinary schistosomiasis compared to those without the infection. IgG is the primary antibody in the body responsible for guarding against blood-borne pathogens, which accounts for the high serum level of IgG in women with urinary schistosomiasis. Conversely, IgA is the main immunoglobulin responsible for protecting mucosal surfaces. Thus, a significantly lower serum level of IgA is found in pregnant women without urinary schistosomiasis compared to those with infection. These findings indicate that serum protein are valuable immunologic diagnostic tool. 2. Immunization against infectious disease. Tetanus is an acute infectious disease characterized by tonic spasm of the voluntary muscles, particularly those of the jaw, resulting from exotoxin produced by the bacterium Clostridium tetani, which reside in the soil, stool, or inanimate objects. This is a serious yet preventable disease. Skin lesion caused by either HIV infection or adverse drug reaction are known to lead to different morbidity in patients with HIV. Because of the possible contamination of the skin lesion from the environment or autoinfection from diarrhea stool in HIV patients, I investigated the need for routine anti-tetanus immunization in patients living with HIV/AIDS. Serum levels of IgG antibody to tetanus organisms were quantified in 42 clients living with HIV/AIDS. I found no significant difference in the mean tetanus antibody level in patients living with HIV/AIDS compared to those without those of the controls. Further analysis showed that mean antibody level to tetanus were not significantly different based on the patient's circulating CD4 positive lymphocyte or their age. By international standard, 85.7% of our HIV/AIDS patients had protective level of antibody to tetanus. In another study on the effectiveness of routine immunization against tetanus post-injury, we conducted a prospective study in a cohort of adults with open wound in the emergency room of HAC. We determined the baseline serum level of antibody to tetanus organism at the first contact and then immunized participants with antenatal toxoid. 4 weeks after the immunization, they were reassessed for serum levels of antibody to tetanus organism. Our study showed a rise of more than 8-fold in antibody level against the tetanus organism, the subject. From this finding, we confirmed the effectiveness of tetanus immunization and the necessity to continue with this preventive measure in patients with open wound due to high mortality associated with infection. It is therefore important to note that assessment of this is a form of warning system because assessment helps detect health problems early before symptoms appear so that steps can be taken to prevent the disease from developing or worsening and to avoid complications. Disease assessment also helps find risk factors even when there are no actual disease yet. For example, exposure to radiation or chemicals can increase the risk of leukemia. Therefore, regular assessment of complete blood count of individuals exposed to chemicals or radiation as a result of their work will be a good preventive measure. After diagnosis, the affected individual can receive specific advice or treatment to prevent the disease from progressing. For example, a pap smear can detect abnormal cells before they become cancerous, and with early treatment, cervical cancer can be prevented. Diagnosis also helps control outbreaks by tracking disease patterns, preventing the spread of disease that are of public health interest, enabling medical research. For example, diagnosing latent tuberculosis infection allows for treatment before they progress to active tuberculosis, thereby preventing further spread and severe illness. Therefore, diagnosis involves not only identifying the disease, but also playing a crucial role in preventing its occurrence or progression. My contribution to hematology, determinants of survival in hematologic malignancy. Hematology not only plays a crucial role in the diagnosis, monitoring, and management of a wide range of blood-specific diseases, but it also provides insight into systemic illnesses, infections, and organ function. The survival of patients with hematologic malignancy is hinged on many variables, including the type of malignancy, some genetic and molecular features, stage of presentation to the healthcare facility, age at presentation, presence or absence of other comorbidities, type and quality of treatment received, access to specialized care, patient's financial resources, and psychosocial support received by the patient. Collaborating with other researchers, we conducted some studies on hematologic malignancies and varieties of factors affecting survival. 1. Multiple myeloma. Multiple myeloma is a hematologic cancer more commonly seen in black population. Disease is characterized by the malignant proliferation of a clone of plasma cell in the bone marrow and the overproduction of abnormal mononuclear protein, which is responsible for the characteristic role formation of red blood cells observable on peripheral blood smear. The mononuclear protein appears as a mononuclear band on serum protein electrophoresis, and the light chain of the abnormal protein can be detected in urine as Ben-Jones protein. It is an invariably fatal disease with a median survival of about 6 months when no treatment is given, and about 3 years with drug treatment. Multiple myeloma has a progressive clinical course with increasing anemia, weakness, bone pain, pathological fracture, hypercalcemia, renal insufficiency, bleeding dialysis, and neurological complications if treatment is not offered early. To predict the survival of a patient at diagnosis by identifying adverse prognosis factor, I investigated 27 patients managed between 1986 and 2001. The study showed that older age, inability to afford the cost of treatment, complications such as anemia, skeletal fracture, renal failure, neurological complications at presentation are important prognostic factors. Of the 21 patients that received chemotherapy, it was inadequate in 18 due to inability to afford the cost of drugs. And only 3 patients received up to 6 cycles of drug combination before death or were lost to follow-up. The median period of their follow-up was 2.75 months, and the median survival was 1.2 months. 12 of them were already dead at the time of analysis of our data as a result of renal failure in 66.7% and anemia in 33.3%. 2. Chronic lymphocytic leukemia, CLL. CLL is an indolent blood cancer that is less common in black population. It is characterized by the gradual accumulation of immunologically incompetent B lymphocytes in the blood, bone marrow, and the lymphoid organs. The clear cause of the cancer is variable, with some patients surviving for many years and sometimes dying with their cancer, while others may have a progressive disease and develop complications that may eventually lead to their death. Many studies have investigated factors associated with poor prognosis and those associated with more prolonged survival. Factors such as favorable genetic and molecular markers, favorable chromosomal abnormalities, early clinical stage of disease at presentation, lymphocyte doubling time of more than 12 months, younger patient, attainment of complete remission when treated, absence of comorbidity is associated with much longer survival. Because the facilities to carry out some of the molecular tests are not readily available in most Nigerian tertiary facilities, investigate the usefulness of some simple biological laboratory parameters in assessing prognosis and survival of CLL patients in Nigeria. I now 17 patients managed over 20 years whose diagnosis was based on clinical and laboratory features such as the presence of peripheral lymphadenopathy, splenomegaly, hepatomegaly, and the presence of lymphocytosis in the peripheral blood and the bone marrow. More than 50% of them had no peripheral lymphadenopathy, while massive splenomegaly and hepatomegaly were recorded in 17% and 29% respectively. However, the unavailability of other diagnostic modalities, such as flow cytometry or immunocytochemistry to rule out other lymphoid malignancies, create diagnostic problem in our setting. More than 80% of them were older than 50 years. At the time of diagnosis, 60% were in the advanced stage of the disease and 74% presented with anemia. Assessing survival based on this simple easily accessible, and available clinical and laboratory parameters, the study found splenomegaly, younger age, male sex, moderate anemia and thrombocytopenia, and a fewer lymph node region as good prognostic factor in our own environment. Assessing survival in patients with hematologic malignancy is very crucial because survival assesses the effectiveness of treatment and compares treatment modalities. The prolonged survival of patients underscores the success of medical research in drug discovery. Assessing survival aids in making informed decisions on approach to treatment as to whether to be aggressive in the treatment, offer palliative treatment, or explore clinical trials, that is, the use of experimental drugs. A longer survival means that more time for the patient to live a quality life with family and work and other pursue personal goals. Survival rates influence funding and healthcare planning. Disease with poor survival often receive more research attention. The survival of a patient often has an emotional and social impact, as each additional month is significant to both the patient and their family. Immunosuppression and anti-cancer drug. The paradox of protection and vulnerability. Nearly all patients receiving anti-cancer drug will undergo some degree of immune suppression. This presents a paradox, as the drug is intended to eliminate the cancer cell without harming the normal ones. However, anti-cancer drugs target rapidly dividing cells and do not discriminate between cancer cells and normal ones. Since blood cells are among the rapidly dividing cells, they are also prone to being affected by anti-cancer drugs. As anti-cancer drugs damage the bone marrow cannot produce enough blood cells. Typically, the main impact is on the white blood cell that is responsible for protecting the body against pathogens. Hence, the body is more vulnerable to various infections, particularly opportunity infections. In addition, their weakened immune system may also lead to the reactivation of latent infections and autoimmunity, life-threatening sepsis, delayed wound healing, increased risk of secondary malignancy, and vaccine ineffectiveness. Because of these serious consequences, I set some immunologic parameters of chronic myeloid leukemia patients, anti-cancer drug, Glivec in UHAC. 1. Glivec and immune suppression. Based on the knowledge of the effect of anti-cancer drug on blood cells, I carried out a study on the impact of Glivec, a targeted therapy on patients with CML. Baseline complete blood count and circulating CD4 positive lymphocyte count were assessed in this patient before commencing Glivec at a standard dose of 400 milligrams daily and at 6 months on the drug. There was a singular reduction in the CD4 positive lymphocyte count and absolute lymphocyte count after 6 months of therapy. The CD4 positive lymphocyte count are central to the functions of the immune system in the control of adaptive immunity against pathogen and cancer cells by activating the other effector immunocyte. Although several workers have reported severe microbial infection in patients using Glivec, none of the patients in our study developed any infection. However, the short period of observation, the fact that the mean absolute number of circulating CD4 positive lymphocytes and lymphocyte count while within reference values might have a mitigating effect on the reduction of the absolute lymphocyte count. The study, however, confirmed that Glivec can cause lymphopenia. In another study, outside the humoral arm of the immune system, the study determined the serum level of IgG, IgA, IgM, albumin, and globulin before initiating Glivec treatment, and 6 months into the treatment. I noted a significant reduction in IgA concentration, but a non-significant increase in IgG and IgM 6 months into treatment. The reduced IgA may lead to mucosal infection, particularly respiratory tract infection, indicating that this should be monitored while patients are taking this medication. On the other hand, the mechanism by which the production of both IgG and IgM, which are crucial in combating blood-borne infection, is trivially stimulated and become more abundant while using Glivec is unknown. These studies on the effect of Glivec suggest that the drug has some deleterious effect on some aspect of immunity. 2. Glivec and reactivation of latent viral infection. The administration of Glivec in gastrointestinal stromal tumors, GIST, has been very effective as neoadjuvant and/or adjuvant therapy. Most Glivec-related skin lesions include self-limited dermatitis and others. Although unusual presentation of GIST are not uncommon, de novo immunosuppression is not a typical presentation. About 2 years into the use of liver therapy for GIST, we reported the case of a 56-year-old man who developed multiple painful and tender blisters with distinctive dermatoma distribution over the left side of the trunk. Serial neutrophil, lymphocyte, and CD4 positive cell count were within normal values. The dermatoma presenting of a vascular rash associated with severe pain is characteristic of herpes zoster infection. He was treated with a cyclophosphamide and showed significant improvement in symptoms within 1 week. Considering that the absolute lymphocyte and CD4 positive cell count were adequate, a functional defect in cell-mediated immune mechanism leading to the reactivation of latent varicella zoster virus is the only plausible explanation for this presentation. Since the infection responded well to antiviral therapy, we concluded that reactivation of latent herpes infection is possible in patients with GIST on Gleevec therapy, and that Gleevec may interfere with cell-mediated immunity. Aside from the increased risk of infection and reactivation of latent infection noted in the above studies, immunosuppression can delay and interrupt treatment and cause complications that may directly increase mortality independent of cancer progression itself. Immunosuppression can cause vaccine to be less effective or ineffective because the immune system cannot mount a strong immune response. Long-term immunosuppression can increase the risk of secondary malignancy and can also negatively impact on the quality of life for patients, as prolonged hospital stay can significantly affect their physical, emotional, and social well-being. Therefore, patients can achieve better overall health and functionality by physicians balancing the need for immunosuppression with protection from the disease they are managing, particularly malignancy. My contribution to blood transfusion safety and modern innovation. Transfusing blood is no doubt a life-saving procedure. However, it may be associated with some hazard if safety measures are not implemented, particularly the transmission of transmissible infectious disease and allergic transfusion reaction. The essence of screening intending blood donors is to ensure that the donation is not harmful to the donor and that the donated blood does not constitute a potential vehicle for transmitting infectious disease or pose any hazardous effect to the recipient. The safety of patients receiving blood transfusion has improved over the years due to the enhancement in donor screening, eligibility criteria, and laboratory testing methods. 1. Antibody screening method for infectious disease agents in blood donors. A large pool of blood donors is not easy to obtain in most blood donor centers in Nigeria. Donors arrive in trickles, primarily during urgent situations. The practice at the time was to pool donated blood and screen the unit for infectious disease agents before transfusion. However, the increase in incidence of HIV and other TTIs prompted the recommendation for pre-donation screening to reduce laboratory staff exposure to TTIs. This will also decrease wastage in screening materials and reagents and allow for counseling blood donors who tested positive for TTI on the need for appropriate treatment. Consequently, I conducted a study to determine the effectiveness of pre-donation screening for intending blood donors. 1,250 intending blood donors were screened pre-donation. 151 of the donors were rejected due to positivity for TTIs, microvilli infection, and anemia. The study showed that 151 bags were conserved by a pre-donation screening method. Disposing of infected blood also involved using disinfectant, thereby reducing the financial loss to the blood bank. Since blood bank relied more on commercial blood donors, the pre-donation screening reduced the number of high-risk donors who may want to conceal their high-risk behavior during pre-screening counseling for fear of rejection. The method also reduced the risk of exposure of blood bank staff to TTIs. While it afforded the opportunity of counseling those found positive for TTIs on the treatment option available and preventing method to adopt to avoid spread of the disease to their spouses, loved ones, and caregivers. This study informed the current practice of screening all potential blood donors in UHSC before being bled. occult hepatitis or hidden hepatitis. Is this an indication of failure of antibody screening just described? Advances in the genomic application of viral DNA have shown that it is possible to be infected with hepatitis virus but be negative for hepatitis surface antigen, which is one of the criteria used to exclude donors. This has shown that reliance on antibody testing in screening for transmissible infectious disease, as commonly done in most global and resource-limited economies like Nigeria, may be fraught with false negative results. Studies have shown that occult hepatitis B virus infection increases hepatocellular carcinogenesis by 8 times. Because of this observation, I conducted a prospective study on the burden of occult hepatitis virus infection in a pool of predominantly commercial blood donors. 457 prospective donors who were negative for antibodies to TTIs were recruited. The serum samples were tested for anti-HBC, anti-HBS, anti-HBE, HBE antigen. 80 of the prospective donors who were initially considered fit to donate blood based on hepatitis surface antigen negativity were found to be positive for other markers of hepatitis virus infection. 25 were positive for anti-HBC, 58 were anti-HBS positive. While some investigators found the viral DNA, that is, the virus DNA, in subjects positive for anti-HBC, others did not. However, despite the non-detection of the virus DNA in blood samples positive for anti-HBC antigen, there were reports of post-transfusion hepatitis virus infection in recipients positive for anti-HBC. Similarly, serum from patients with anti-HBS antigen, evidence of recovery for hepatitis virus infection, and a sign of protective immunity has been shown to contain virus DNA. Studies have also shown that lymphoma and HIV patients with positive anti-HBS have detectable virus DNA in their serum. It could be inferred from this report that serum containing anti-HBS and anti-HBC can transmit the virus infection, emphasizing the importance of significant markers of hepatitis virus infection, which can reduce post-transfusion hepatitis virus when screened for. Therefore, this study has shown that we might have been under-assessing the prevalence of hepatitis virus infection and blood donor by simply using hepatitis surface antigen negativity alone as a screening criterion, because this study showed that 17.5%, or approximately 1 in every 6 donors investigated, is a potential carrier of hepatitis virus infection that can transmit the infection to the strength of their blood. There is therefore a need to include other markers of hepatitis virus infection to reduce the prevalence in our environment. So how do we improve the screening protocol for TTI, the nucleic acid testing option? Since the screening protocol in Nigeria for hepatitis virus infection does not include the detection of occult hepatitis virus infection, we sought to determine the prevalence of OBI at OHAC using the presence of hepatitis virus DNA marker to enable us make an informed recommendation for effective hepatitis virus screening to prevent the transmission of hepatitis virus from blood donor to our patient. The study recruited 502 intending blood donors who were initially negative for hepatitis surface antigen, out of which 345 were found positive for antibody to hepatitis virus or antigen. The detection and quantitation of hepatitis virus DNA in the anti-HBC positive samples were done at the Human Laboratory, Biology Laboratory of the Nigerian Institute of Medical Research in Lagos. However, out of the 345 donors positive for anti-HBC, 19 had hepatitis virus DNA in their serum, signifying occult hepatitis virus infection. In some earlier studies, Ina et al., Aketulu et al., and Opalaye found 8%, 8.7%, and 11.2% respectively in their study. These studies show that occult hepatitis virus infection exists in our blood donors, and that the use of hepatitis virus antigen alone for screening prospective donors, as well as being done in some blood banks, will not eliminate the risk of hepatitis virus infection in Nigeria. This calls for adopting nucleic acid testing method for testing blood donors in our various hospital blood bank and the National Blood Donation Center to halt the spread of TTI. However, aside from preventing blood-borne infection, screening maintains healthcare trust, encouraging donation and their use for medical treatment. Blood screening can detect early spread of infectious disease in the population and allow for prompt public health response. The screening of blood also protects vulnerable groups such as surgical patients, cancer patients, and those with blood disorder who often require blood transfusion. Blood screening will also meet legal and international organization standards, such as those set by the WHO, which establishes strict guidelines to ensure that donated blood is safe. My service to the university, other institutions, and organizations, Obafemi Awolowo University. Mr. Vice Chancellor, sir, I have taught undergraduate medical and dental students hematology and immunology since 1999. I've also taught several postgraduate students and supervised 4 MSc and 2 PhD students in immunology. I was appointed the acting head of the Department of Hematology and Immunology in February 2007 and continued in this position till July 2011, during which I was able to resuscitate the postgraduate program in immunology and later became the coordinator. In October 2015, I was appointed the chairman of the Faculty Postgraduate Committee and a member of the board of Postgraduate College and Academic Research Committee until August 2021. I was appointed the substantive head of the department in August 2020, serving till July 2021. I also served as the dean of the Faculty of Basic Medical Sciences from August 2021 and July 2023. In addition, I have served the university in other capacities, including the dean's representative to the faculty boards of the Institute of Public Health and Institute of Ecology, faculty representative to the faculty board, selection panel, and review of the Faculty of Science. I've also served the university as an examiner to the Postgraduate College, Senate representative to the University Development Committee, and Finance Subcommittee. Tertiary Education Trust Fund, TED Fund. I served in the Tertiary Education Trust Fund Technical Advisory Group, TAG, between August 2019 and November 2023. During this period, I promoted the writing of the pathology textbook for medical and dental undergraduate students to be published by TED Fund. In collaboration with Professor A. Abegunde of the Faculty of Environmental Design and Management, we convinced TED Fund TAG to patronize OAU Press Limited in book publication. The first set of 10 basic textbooks for students in tertiary institutions was delivered to TED Fund by OAU Press Limited April 2024. Obafemi Awolowo University Teaching Hospitals Complex, OAU-TAC. Mr. Vice Chancellor, sir. In addition to serving OAU, I could serve the OAU-TAC in various capacities. I was appointed the head of the Department of Hematology and Blood Transfusion and a member of the Postgraduate Committee in August 2007. I served in this position till July 2011 and also between August 2020 and July 2021. I served as a member of HTS Committee on antiretroviral therapy and prevention of mother-to-child transmission. I was the chairman of the Laboratory Revolving Fund Committee between 2010 and 2011. I had the rare privilege of serving as the Hospital Acting Chief Medical Director between July 5th and September 28th, 2023. I have contributed to training resident doctors at the HTSC and supervised the fellowship dissertation of 34 resident doctors. Aside from HTSC, I've also contributed to training of many resident doctors in hematology in other teaching hospitals in Nigeria. Many are now consultants in various institutions, both within and outside Nigeria. Other universities. I have served as the external examiner to several medical schools and as external reviewer for professional cases of many universities, professional bodies. I am a member of several national and international professional bodies, including the National Postgraduate Medical College of Nigeria and the West African College of Physicians, for which I have served as an examiner, sub-chief examiner in hematology, assessor, educational resource person, and member of the education team to several teaching hospitals on behalf of this professional body. I was the training coordinator and a member of the Education and Research Committee of the Faculty of Laboratory Medicine of the West African College of the Physicians between 2015 and 2018. I am a member of the Committee on the Doctor of Medicine MD program for the Faculty of Pathology, National Presiding Medical College of Nigeria. Conclusions and recommendations. Mr. Vice Chancellor, sir. Pathology is often called the science behind the cure because it plays a central role in understanding diseases, their causes, and their mechanism, which are essential for developing treatment and cure. So the hematologist, blood serves as a tool that aids in unraveling the nature of disease. It is useful in screening for those yet to be clearly diagnosed. This is a means of predicting the risk of an individual being affected by a particular disease. Decision on treatment modalities that can be chosen or necessary treatment modification can be suggested from the result of blood tests. The result of blood tests can be used to monitor treatment compliance or its effectiveness. In addition to making specific diagnosis, blood tests, screening for disease is a cost-effective measure to detect disease and initiate treatment much earlier for a better outcome. Blood transfusion is much safer today because tests are done to determine the compatibility between the donor and recipient and to exclude donors with transfusion-transmitted infectious diseases. Mr. Vice Chancellor, sir, distinguished audience, recent advances in diagnostic technology in hematology, such as advanced flow cytometry, have made it possible to detect and characterize blood cells with high precision and aid diagnosis. Artificial intelligence enhanced blood smear analysis allows the detection of abnormal cells. Next generation sequencing technology identifies genetic mutations linked to blood disorder, opening door for personal medicine. Therefore, we should not wait for occasions such as when we wish to travel abroad or take up employment to make carrying out medical tests mandatory. It is advisable to detect a potentially life-threatening disease well before it escalates to an invasive health crisis and that is difficult to manage. A regular medical checkup can identify disease that can be nipped in the bud. A medical checkup can establish whether our vital organs are functioning well. A medical checkup can establish if you have markers for disease or cancer, or if you are susceptible to certain genetic conditions. As diagnostic technology advances, blood tests are becoming increasingly precise, further enhancing our ability to detect and treat disease at early stage, as well as monitor and plan effective treatment. I therefore encourage everyone here today to undergo medical tests at least once a year, even when they are healthy, because blood is more than just a life-sustaining fluid circulating through our bodies. In blood, we find the script of our DNA, the chemical whisperer of our health, the silent warning of disease. Our blood is a sediment of the lineage we carry. Like a mirror, blood reflects the state of our body and mind. Inflammation, infection, stress, and love all leave their mark on its flow. Blood is therefore nature's powerful mirror reflecting our internal health. Appreciation. Mr. Vice Chancellor, sir. I sincerely thank all my teachers, starting from my primary school at the Roman Catholic Mission School, Sokoto, Local Authority Primary School, Isale Oyo, St. Luke's Primary School, Idode, along Oyo Ogbomoso Road. I appreciate all my teachers at the Asarudin Secondary Modern School, now Asarudin Grammar School, Opapa Oyo, Orion Grammar School, Oyo, as well as my teachers at the Federal School of Arts and Science, Ondo. They all have contributed in one way or another to my success in life. My full appreciation goes to my teachers in the Faculty of Science of this great university and the then Faculty of Earth Sciences. May the Lord Almighty reward them abundantly. I acknowledge with gratitude my trainer, Professor Eme Drosimi, for his contribution to my success. I appreciate the contribution of Professor Enio Akinola, Professor Ari Togun, Professor Ari Bolaniwa, Dr. Oti Owojibe. I also appreciate the contribution of my colleagues in OHAC, Dr. Oji Olariwaju, Dr. Mayola, Dr. Oguns, Dr. Ahmed. May Almighty God reward every one of you. I want to express my heartfelt appreciation to the laboratory technologists in the Department of Hematology and Immunology, OAU, and the laboratory scientists and nurses in the Department of Hematology and Blood Transfusion, OHAC, for the cooperation I enjoy working with them. I'm eternally grateful to my late parents for their enormous sacrifice and contribution to my life. I appreciate my wife and children for their unwavering love and support. In the Holy Quran, chapter 55, Surah Ar-Rahman, or the most gracious, Almighty Allah brings to our remembrance the many favors he bestowed on mankind, and then asks, then which of the favors of your Lord will you deny? Indeed, none of the favors of the Almighty Allah is deniable. Therefore, my unquantifiable gratitude goes to Almighty Allah for his innumerable favor to me, including the favor of this inaugural lecture. Therefore, glory to thy Lord, the Lord of honor and power, is free from what they ascribe to him, and peace on the messengers, and praise to Allah, the Lord and Chancellor of the world. Mr. Vice Chancellor, sir, distinguished audience, I'm highly honored by your presence here today and sincerely grateful. May God Almighty bless you all. Amen. Thank you all, and God bless.
Haematology University, Lateef, certificate of presentation of inaugural lecture. This certifies that Lateef Salawu, a professor of hematology and immunology in the Department of Hematology and Immunology, Faculty of Basic Medical Sciences, College of Health Sciences, Haematology University, Lateef, Nigeria, delivered the 400th inaugural lecture titled Blood is Health. Our blood mirrors our being, on June 24, 2025. Congratulations. Congratulations to you.